Thank you for joining this presentation about MACRA and the Quality Payment Program. What's new in 2020, Performance Year 4. I'm Terry McWilliams, a Director and the Chief Clinical Consultant here at HSG, and the host presenter of the webinar. My bio and contact information can be found at the conclusion of the presentation should you desire to contact me about anything related to this topic. Let's go ahead and review the agenda for the presentation. So we plan to give just a brief review of the Quality Payment Program background information, particularly that's pertinent to the 2020 program. We'll look first at what's new for the MIPS pathway and introduce a new concept that CMS is proposing be implemented in Performance Year 2021. That's the MIPS value pathways. We'll then talk briefly about the advanced APM pathway because there's very little new there. And then also a brief look at the one or two new things in the public reporting world. So with that, let's go ahead and get started. You recall that MACRA stands for the Medicare Access and Chip Reauthorization Act of 2015. That big mouthful is why everybody just calls it MACRA. That was the legislation that created new Medicare physician reimbursement methodology. And while CMS was setting up the regulatory process, permitted an annual increase of 0.5% in the physician reimbursement rates from 2015 through 2019. Starting in 2019 and going probably into the future, but listed as through 2023, any increase or decrease in the physician reimbursement rate would come through participation of one of two pathways. Either the merit-based incentive payment system, affectionately known as MIPS, or the advanced alternative payment model, abbreviated Advanced APM Path. The CMS regulatory process dubbed the implementation program as the Quality Payment Program, abbreviated as QPP, and any CMS regulation that's implemented based on or for the QPP must be based on the legislative requirements of MACRA. So as mentioned, 2020 is Performance Year 4 for the program, and with this final rule, CMS indicated participation rates by eligible clinicians across the country. Clearly, the 2019 participation data were not available at the time of the final rule, which was promulgated in November of 2019. But for Performance Year 2018, 98% of eligible clinicians participated in MIPS, compared to just 95% the year before. Of note, CMS had indicated that they anticipated that more and more individuals would qualify through the advanced APM path. And indeed, in year 2, which was Performance Year 2018, almost double the number of qualified participants participated in the advanced APM path compared to the first year. So more than 183,000 in 18 compared to just over 99,000 in 17. Also recall that 2020 provider reimbursement, or at least for the eligible clinicians for the QPP, will be linked to their 2018 performance in the program. 2019 was the first year that reimbursement was dictated by MACRA performance. And that payment year was based on performance in 2017. Recall that performance lags payment by 2 years. One other background information to emphasize, that the Bipartisan Budget Act of 2018 legislatively allowed some latitude in the implementation timeline that MACRA had mandated. The Bipartisan Budget Act extended the gradual transition process that was contained in the original legislation, and had that gradual transition process extended through Performance Year 2021. By current legislative mandate, the original parameters for MACRA must be implemented by performance year 2022. Two items that are particularly relevant to this year's performance categories. The cost category was allowed to be between 10 and 30%, which delayed increases to the MACRA mandated 30% level until performance year 2022. The other area is that CMS was allowed to have a lower performance threshold if it felt that that was merited. Recall that the original MACRA legislation indicated the performance threshold would be the mean or median final score from the prior period. That requirement was delayed till performance year 2022, and CMS had latitude to continue to set the performance thresholds by regulations. So as mentioned, the 2020 final rule criteria were published in the Federal Register on November 15th, 2019, after having been released by CMS on November 1st. So out of the gate, the final rule confirmed the increased bonus and penalty percentage for the program at 9% as planned in the original legislation. Recall that the 9% decrease would happen for the lower quarter of performers in the MIPS program, and the top performers may not get up to 9% because the gains have to be balanced by the losses to be budget neutral. So there are scaling factors that can affect the degree of gain that those who exceed the base threshold can receive. CMS established the base performance threshold at 45 points in performance year 2020 and indicated that they plan to have the threshold being 60 points in performance year 2021. CMS also established the exceptional performance threshold at 85 points for both performance year 2020 and 2021. In the proposed final rule, CMS had indicated an increase to 75 points from 75 points to a proposed 80 points, with a gradual increase then to 85 points in 21. Between the proposed rule and the public comments that received, they indicated that the public felt comfortable with increasing just to 85 points for 2020 and 2021. Recall that the exceptional performance threshold allows the top performers in the MIPS pathway to receive additional bonuses above the base percent increase that's funded by a separate pool of $500 million per year through at least 2022. The quality performance category remains weighted at 45% of the final score. That is due to there being no change in the weight of the cost category. Recall that as the cost category increases, the quality category will decrease in its weighting. CMS increased the data completeness criteria to 70% of all eligible patients, up from 60% in 2019. They continue to remove topped-out and low-bar process measures as part of the meaningful measures framework that they introduced last year. And they added new specialty sets, particularly specialty sets that are targeted to the new clinician categories added in 2019. Probably the most sweeping change in this area involved revising the quality clinical data registries, or the QCDR requirements. These will be implemented in 2021 but promulgated in the 2020 final rule. QCDRs must be able to report all performance categories, not just quality. to allow for minimizing barriers to participation and decreasing the burden on reporting clinicians. The QCDRs are required to provide more robust feedback to participants on a more frequent basis, as well as with comparisons to other members of the QCDR, so that they can measure performance related to cohorts in the registry. And finally, they mandated that QCDRs work with each other to fully develop, vet, and even consolidate measures between them. This allows a more restrictive process for developing and implementing metrics to make sure that they're more reliably achievable and more reliably measure actual quality of care. In the improvement activities performance category, the category remains weighted at the legislative weight of 15% of the final score. And as last year, they added 2 new activities, modified 7 existing activities, and removed 15 existing activities. In the 2020 final rule, CMS indicated specific criteria for activity removal, just as they had previously indicated specific criteria for activity additions. This follows the processes in place for the quality performance category metrics. A significant difference in improvement activity category this year is that CMS is requiring 50% of clinicians in the group to have participated in the same reported activity for a continuous 90-day period during the performance year. Previously, a group was only required to have 1 member documented as participating for that period of time. This significantly increases the weight of the category, and the emphasis is that this should be now an improvement indicate activity, that is well established within the group and has significant participation within the group. And finally, CMS revised once again PCMH designation criteria. In the 2019 final rule, they had settled on recognition by one of 4 national organizations, and now they went to more broad and general criteria that were in place in 2018. These same criteria apply to other designations such as PCSP, the Patient-Centered Specialty Practice criteria. Promoting interoperability remains weighted at its mandated 25% aspect of the final score. And this is one of the areas where the 2020 final rule actually changed 2019 reporting criteria. It altered the optional query of the prescription data monitoring programs to a yes or no response as opposed to a numerator over denominator response, and they continued that methodology through performance year 2020. They also adjusted the points redistribution for the measure listed, and for 2020 removed the Verify Opioid Treatment Agreement measure from the performance category criteria or requirements. We mentioned that the cost performance category stayed the same at 15% of the final score, which allowed the quality performance category to remain weighted at 45%. CMS had proposed an increase from 15% to 20%, but were encouraged to leave the category unchanged based on the additions made during performance year 19. Specifically in performance year 19, CMS added 8 episode-based measures that they would interpret claims data for performance in, and added 10 more episode-based measures in the 2020 final rule. In addition, CMS revised the total per capita cost measure and the attribution process associated with it, and revised the Medicare spending per beneficiary measure, also revising the attribution process, creating different methodologies for medical and surgical episodes. Based on these continued sweeping changes, CMS decided to leave the category weighted at 15%, knowing that the category must be weighted at 30% by performance year 22. This would indicate that next year's weighting would likely be increased because CMS would be reluctant to double the weight in just a single performance year. Just as pertinent to areas with change include the following areas that have no changes in the 2020 final rule. The low volume thresholds remain unchanged. The eligible clinician types remain unchanged from 2019. There was some conjecture that perhaps this would change and have increased types of clinicians progressively over time, but that has not occurred this year. All individuals will be required to utilize the 2015 edition of the Certified EHR technology. Bonuses for high priority measures and end-to-end electronic reporting remain in place, as does the small practice bonus. We mentioned that there's a new aspect of the Quality Payment Program, MIPS Pathway, projected to be implemented in performance year 2021, and that's the MIPS value pathways, which CMS is abbreviating MVPs. CMS is introducing this new framework to try to align and connect measures and activities across the 4 MIPS performance categories. This is in response to feedback received from participants and tries to address the complexity of the reporting process, understanding how these are or can be linked together in operationalizing procedures to implement these activities. And they've introduced this integrated approach to performance measurement. They've also introduced the opportunity to further utilize administrative claims-based quality measure reporting in place of separate participant reporting once a year. They indicated that the MVPs will be based on areas that focus on population health and public health priorities, and will include enhanced data and feedback frequency, feedback frequency given to providers rather than just subsequent to the reporting process. While the details clearly have to be developed, and the devil's in the details for this program, you can see the plan diagrams, view a video, and read about additional details about MIPS value pathways on the listed CMS website. That website is dedicated to this process and is already more robust than it was just a couple of months ago. From the website, CMS depicts its intentions with the program in this diagram. On the left column is the current structure of MIPS, characterized by having many choices, not having the performance categories meaningfully aligned for any given participant, and based on participant feedback, entails a high reporting burden. On the far right column indicates the CMS envisioned future state, which they feel will be in place in the next 3 to 5 years, of a simplified system that integrates the performance categories, increases the voice of the patient, increases use of CMS provided data, which is designed to decrease the reporting burden on clinicians, and they feel moves toward the pattern of care that would be emblematic of the the APM pathway, where you have integrated aspects of all these things, where the performance on the 3 functional categories directly and positively impact the cost of care rendered. To get there, they're moving to value starting in the next year or two, creating a more cohesive utilization of the performance categories, decreasing progressively the reporting burden on participants, and focused on the pathways, as mentioned, that will be more meaningful to a clinician specialty or a public health priority. CMS listed 2 examples on their website. The first related to diabetes care and was one of the specific requests by participant feedback in the public comment period for the proposed to final rule. And that is, if we are going to report hemoglobin A1Cs greater than 9, why does that also not directly link without further reporting requirements to the improvement activity of having in place glycemic management services? Thinking that both of these might impact the total cost of care in the 2 primary cost measures. So CMS utilized that to create an example, in this case an endocrinologist, because some of these are more specialty specific, and how through the MIPS value pathway the reporting burden might decrease, how the categories might be more fully integrated, and how CMS could use data through the claims submission process. CMS created a similar example for surgical services areas in which these categories could be combined and moved through the progression to the future state that CMS anticipates MIPS could evolve into. Shifting gears to the advanced APM path, the major significant change for that pathway was finalizing a new definition for aligned other payer, multi-payer medical home model definition. The 2 major criteria, or the simplified version, is that this must be in conjunction with the CMS agreement, and the requirements are consistent with the Medicaid Medical Home model. This expands the medical home pathway in a manner similar to the expansion of the APM model from just the CMS recognized programs or backed programs, i.e. the MSSP and the next gen pathways, to other payer models. And so this does the same thing for medical homes. Related but not absolutely part of the advanced APM pathway, but reported in that section in the final rule, is a change in the MIPS APM quality reporting process, or a permitted latitude in that reporting process. You may recall that organizations that participate in MSSP Track 1 ACO programs are not eligible for the advanced APM pathway because the Track 1 programs do not have downside risk. However, participation in these programs does allow a different scoring methodology than the regular MIPS pathway. For instance, MIPS APMs do not separately report quality data to CMS, but the ACO of which they're a part report the quality data for them. In that process, the participating organization receives the general aggregate score for the entire ACO. Considering the variability of organizational performance within the ACOs, some organizations perform quite well, while others have not committed to improving performance in their ACO measures, but merely report measures. This inequity has led some high-performing organizations to indicate that they would have been eligible for the exceptional performance bonus, but were dragged down, so to speak, by other ACO members. This has led to CMS now permitting individual reporting of MIPS quality measures in a fashion to how the MIPS APMs report their Promoting Interoperability measure performance at either the NPI or TIN levels. This does allow, this can be very individual organization pertinent and can lead to enhanced reimbursement through the program. Similar to what's in place for these MIPS APMs in the improvement activity category, in which just mere participation in a CMS ACO program engenders a minimum score of 50% of the final score for the improvement activities category. These same ACOs are going to have a minimum score of 50% on their quality score just based on APM participation, and their individual performance enables the final score balance. Again, a lot of the changes in 2020 are based on direct input through either the public comment periods for the CMS final rules for the quality payment program, but also in various listening sessions where CMS specifically solicits input regarding the program. This MIPS APM change is clearly one of those that is based on participant input. Finally, public reporting changes due out late in 2019, but I think just now appearing. The aggregate MIPS performance year 2018 data is or will be available on Physician Compare. And the link between Physician Compare and Hospital Compare sites for the hospital-based eligible clinicians who use facility-based measures is anticipated to be up on the site in late calendar year 2020. So not much new there. All right, so that's what's new for the quality payment program in performance year 2020. For more details, again, the CMS website is very good for this program, and it's www.qpp.cms.gov. Has a lot of information about the entirety of the program, including details about all the metrics and measures available for performance year 2020. We hope that your reporting for 2019 has gone or is going smoothly, since the deadline is fast approaching. And as you turn your sights towards 2020 performance, we hope that this information is helpful to you and allows you to avoid a lot of research on your own. As always, please contact me if I can be of any help with this program or any other. As you will note, my contact information is at the end of the presentation and will be available on the website at all times. Thank you very much for participating, and we hope you'll join us for future webinar events, not only about the quality payment program, but about other topics of interest.
Welcome to the webinar. You have entered as an organizer and may now speak to any other organizers or panelists on the line. When you are ready to begin the presentation, press the Start Broadcast button on the GoToWebinar control panel to allow all attendees to hear you.